All right, so you're prepping for the NCLEX,
Yep.
and we know ECG interpretation is a big deal, especially if you're thinking critical care.
Oh, absolutely.
You've been smart to grab some materials from Shift Fuel. They have
Yeah.
some really good stuff there.
Yeah.
And today we're going to help you decode all those squiggly lines and make sure you're totally confident when it comes to tackling ECG questions on that NCLEX.
Awesome.
And let's be real, the NCLEX loves to throw in those life-threatening
Oh,
arrhythmias.
yeah.
So we're going to make sure you can spot those from a mile away.
We will.
Okay, so let's unpack those ECG basics. What are the key components we need to know to crack the code?
Yeah, so think of an ECG like a sentence.
Okay.
It's telling a story about the heart's electrical activity.
I like that.
And each component's like a word giving us clues about what's happening.
Okay.
So first we have the P wave,
Okay.
which represents the atria contracting and sending that signal down the line.
So the P wave is like the atria saying, hey, ventricles, get ready to work.
Exactly. And then comes the PR interval, that brief pause before the ventricles kick in.
Okay.
It's like the atria giving the ventricles a heads up.
A little heads up.
Exactly. And normally that pause is between 0.12 and 0.2 seconds.
So if that PR interval is longer than 0.20 seconds, what does that tell us? Is that something we need to be concerned about?
Yeah, it could be. A longer PR interval might mean there's a delay or block in that electrical pathway,
Uh-huh.
like signals getting stuck in traffic.
Oh,
That's definitely something we want to investigate further.
okay. Interesting. So after that little pause, we get to the main event, the QRS complex.
Right, the QRS complex represents the ventricles contracting the big squeeze that pumps blood out to the body.
Mm-hmm.
And the normal QRS complex is super fast, usually lasting only 0.06 to 0.10 seconds.
Okay, so if we see a QRS that's wider than 0.10 seconds, it's like a red flag waving,
Absolutely.
telling us to investigate further.
Totally. A wider QRS could indicate a problem with the ventricles, like a bundle branch block, which means the electrical signal isn't traveling through the heart as efficiently as it should.
So we've got the atria contracting the pause, the ventricles contracting. What comes next in our ECG sentence?
Next up is the T wave, which represents the ventricles relaxing and getting ready for the next round.
Okay, so the T wave is like the ventricles taking a breather
Exactly.
before they have to pump again.
Uh-huh. And we can't forget the ST segment, that flat line between the S and T waves. Now, this segment can be a bit sneaky. If it's elevated or depressed, it can be a sign of trouble brewing,
Okay.
like ischemia or a heart attack.
So imagine you're caring for a patient with chest pain and you notice their ST segment is elevated. What's going through your head as a nurse?
Oh, that's a huge clue that they might be having a heart attack and we need to act fast.
Right.
Time's muscle when it comes to heart attacks.
Yeah.
So recognizing that elevated ST segment can be life-saving.
Wow, that's powerful. Okay, and finally we have the QT interval, which I remember can also be a bit tricky.
Right, the QT interval covers the entire ventricular party, depolarization and repolarization.
Okay.
It's usually between 0.36 and 0.44 seconds.
Mm-hmm.
But remember that QT interval can be sneaky.
Okay.
If it gets too long, it can throw the heart's rhythm off and lead to a dangerous situation called torsades de pointe.
Okay.
You'll definitely want to catch that early on.
Okay, I'm starting to feel like an ECG detective already.
Go ahead.
We've got our P wave, PR interval, QRS complex, T wave ST segment, and QT interval.
Yeah.
All the pieces of our ECG sentence. Now, how do we actually put those pieces together and analyze a rhythm? I know Shift Fuel has a helpful step-by-step approach.
Yeah, they do. And that systematic approach is key for breaking down any ECG you encounter. It's like following a recipe.
Yeah.
You follow the steps and you'll end up with a delicious, an accurate interpretation.
Okay, I'm hungry for knowledge. What's the first step in our ECG recipe?
First up, we need to figure out the heart rate.
Okay.
How fast is that ticker ticking?
So how do we actually calculate that from the ECG?
There are a couple of methods. You can count the R waves in a 6-second strip and multiply by 10.
Okay.
Or, if you like a little math shortcut, you can divide 300 by the number of large squares between those R waves.
Okay.
Either way, you'll get your beats per minute.
All right, so we've got the heart rate. What's next on our checklist?
Next, we need to look at the rhythm. Is it regular or irregular? Those RR intervals are key here.
So we're looking for those R waves to be evenly spaced, like a perfectly choreographed dance.
Exactly.
Hmm.
Consistent spacing between those R waves means a regular rhythm, like a well-rehearsed dance troupe.
Yeah.
If they're uneven, it points to an irregular rhythm, like everyone's freestyling out there.
I love that analogy. All right, rhythm check. What's the next clue we're looking for?
Now I got to check out those P waves.
Yeah.
Are they there before every QRS complex, and do they all look similar?
So each QRS should have its own little P wave buddy, and they should all be wearing the same outfit, so to speak.
Exactly.
Yeah.
But if those P waves are missing or looking a little wonky, it could mean the atria aren't firing properly. That's a red flag for some of those arrhythmias we talked about, like atrial fibrillation.
That mnemonic from Shift Fuel is coming back to me now. If you can't see a P, it's AFib. It seems like a simple trick, but it could actually be a lifesaver in a high-pressure situation.
Oh, it definitely can.
Yeah.
And speaking of rhythms that need your attention, atrial fibrillation is a big one, especially because it can increase the risk of stroke.
Okay, so let's talk about AFib. What are the key things we need to know about this tricky rhythm?
With AFib, the atria are basically having a chaotic dance party instead of contracting effectively.
Okay.
So the rhythm is completely irregular, and you either won't see clear P waves or they'll look like tiny erratic waves.
So it's like the atria forgot the choreography and are just doing their own thing.
Yeah.
Why is AFib so risky for stroke?
Because all that chaotic atrial activity can lead to blood clots forming in the heart, which can then travel to the brain and cause a stroke. That's why AFib management is all about reducing that stroke risk.
So if I'm seeing AFib on the monitor, what's going through my head as a nurse? What are my priorities?
Anticoagulants are crucial to prevent those clots from forming,
Okay.
and we also use medications to try to control the heart rate, slowing things down a bit. But it's not just about medication. We also need to educate patients about lifestyle modifications to manage AFib.
Yeah.
Like reducing stress, limiting caffeine and alcohol, and staying active.
Okay. All right, so AFib is definitely one we need to keep on our radar. Now, Shift Fuel mentioned a few other arrhythmias that the NCLEX loves to test. What's next on our list?
Let's talk about the speed demon sinus tachycardia.
Okay.
This one's basically a normal rhythm, but it's just running a little too fast.
So it's like our heart is hitting the gas pedal a bit too hard?
Exactly.
Like-
The rate is over 100 beats per minute.
Okay.
But just like normal sinus rhythm, the rhythm is regular, and those PQRST complexes are all present and accounted for.
So what kinds of things can trigger sinus tachycardia?
Think of the things that get your own heart racing. Fever, pain, dehydration, anxiety.
Yeah.
Those are common culprits.
Mm-hmm.
Certain medications can also rev up the heart rate.
So basically the heart is just responding to what's going on in the body. How do we approach sinus tachycardia as nurses? Do we always need to jump in with medication?
Not necessarily. The key is to treat the underlying cause. If your patient have a fever, we want to bring that down.
Yeah.
If they're in pain, we need to manage that. Rehydrating the patient is also crucial.
Right.
Once the cause is addressed, the heart rate should calm down on its own.
Makes sense. Address the problem, address the rhythm. Okay. Now, on the opposite end of the spectrum, we have the slowpoke sinus bradycardia.
Ah, yes. The heart is taking it easy with this one. The rate is less than 60 beats per minute, but the rhythm is still regular, just like with sinus tachycardia.
So it's slow but organized. Is that always a bad thing? I know some athletes have really low resting heart rates.
You're right. Sinus bradycardia can be normal in athletes because their hearts are super efficient. They can pump enough blood with fewer beats. But if it's not an athlete, we need to investigate a little further.
What else could cause sinus bradycardia besides athleticism?
It could be a sign of hypoxia, which means the body isn't getting enough oxygen. Or it could be a side effect of certain medications, especially those that affect the heart. Sometimes it's just the vagus nerve being a bit overzealous, slowing things down.
Okay, so we need to look at the whole picture, not just the heart rate. What's our game plan as nurses when we encounter sinus bradycardia?
It all comes down to symptoms.
Okay.
If the patient's feeling fine, then we might just monitor them closely. But if they're dizzy, lightheaded, or have low blood pressure, then we need to act fast. Atropine is the go-to medication to speed up the heart rate in those situations.
Interesting. So atropine is our go-to for bradycardia when the patient's symptomatic. Does it always work? Are there any situations where we might choose a different medication?
Great question. Atropine is usually effective, but there are times when it might not be the best choice. For example, if the bradycardia is caused by a heart block, atropine might not be as effective, and we might need to consider other medications or even a pacemaker.
Okay, so we always need to think critically and consider the underlying cause before we jump in with a treatment. Now let's move on to some of the more serious arrhythmias. Shift Fuel mentioned ventricular tachycardia. Can you tell us more about that one?
Ventricular tachycardia, or VTach, is where things start to get really serious. This means the ventricles are firing off way too fast, between 100 and 250 beats per minute.
Wow.
And those QRS complexes are wide and bizarre looking, a telltale sign that something is wrong.
So it's like the ventricles have gone rogue and are just firing wildly.
Pretty much.
What makes VTach so dangerous?
VTach is a big deal because it can quickly deteriorate into ventricular fibrillation or even cardiac arrest.
Right.
We need to act swiftly and decisively to give the patient the best chance of survival.
So what's the first thing we do when we see VTach on the monitor?
Check for a pulse. If there's no pulse, it's straight to defibrillation. We need to shock that heart back into a normal rhythm, and CPR is essential while we're preparing to defibrillate.
Okay, so no pulse, we shock. What if the patient does have a pulse?
If they're stable, we can try medications like amiodarone to calm those ventricles down. Cardioversion, a controlled electrical shock, is another option for stable VTach.
All right, so we have options depending on the situation. Now, what about ventricular fibrillation?
VFib is like the ultimate electrical storm in the heart. The ventricles are just quivering. There's no organized contraction, no blood being pumped. It's a complete chaos on the ECG.
It literally looks like a squiggly mess on the monitor, right?
Yeah.
No recognizable PQ or ST complexes at all.
Exactly. And that means there's no cardiac output, no blood flowing to the brain or other vital organs. VFib is a code blue situation.
Yeah.
We need to jump into action immediately.
So what's our top priority in VFib?
Defibrillation time, S in muscle in this case. Every minute without defibrillation decreases the chances of survival. And just like with pulseless VTach, CPR is absolutely essential while we're getting that defibrillator charged up.
Defibrillation and CPR, the dynamic duo of cardiac arrest care. And finally, we have a systole. What can you tell us about this one?
A systole is the flat line. This one is every healthcare provider's worst nightmare. It's literally a straight line on the ECG. No electrical activity whatsoever, no heartbeat, no pulse, no breathing. It's cardiac arrest.
So what do we do when faced with a systole?
CPR is our only weapon here. We start chest compressions and continue them while we administer epinephrine, hoping to kickstart the heart back into action.
Mm-hmm.
But unfortunately, the prognosis for a systole is not good.
CPR and epinephrine fighting for every chance we can get. Okay, so we've covered a lot of ground here. From those basic ECG components to some of the most serious life-threatening arrhythmias, it's incredible how each of these rhythms has its own unique signature on the ECG and demands a specific set of nursing actions.
It really is.
Oh.
And recognizing those signatures and knowing how to respond quickly and effectively can make all the difference for our patients.
It's amazing how much information those little squiggly lines
I know.
tell us about a patient's heart.
It really is.
It really is. And speaking of guiding our care,
Yeah.
I know you've got some NCLEX success tips from Shift Fuel
Oh, yeah.
that'll help our listeners rock those ECG questions.
They have some really good advice. And remember, practice makes perfect.
Yes.
The more you familiarize yourself with different ECG patterns and in clinical scenarios, the more confident you'll become.
Absolutely. Their first tip is all about memorizing those normal ranges. Knowing those numbers like the back of your hand is crucial for spotting any abnormalities.
It's true. You need those normal ranges as a baseline to compare against. Think of it like knowing the normal vital signs.
Yeah.
You can't tell if something's off unless you know what's normal.
So PR interval, QRS complex, QT interval.
Exactly.
Those are our must-know numbers.
Yep. And remember, the QT interval can be a bit tricky because it varies with heart rate. There are formulas to calculate the corrected QT interval, but for the NCLEX, just having a general idea of the normal range is usually enough.
Okay, good to know. Shift Fuel's next tip is to focus on those life-threatening rhythms. Makes sense? The NCLEX loves to test your ability to recognize and respond to those emergencies.
Absolutely. It's all about prioritizing patient safety. You need to be able to spot VFib, VTach, and asystole instantly and know exactly what actions to take.
So those are the rhythms we really want to master. Any other advice for tackling those NCLEX questions?
Yeah, pay close attention to the clinical context provided in the question stem.
Yeah.
Is the patient stable or unstable? Are they symptomatic? Those details can give you valuable clues about the underlying rhythm and guide your nursing interventions.
It's like putting together a puzzle.
Yeah.
The ECG, the patient's presentation, our nursing knowledge, we have to consider all the pieces to get the full picture.
Exactly. And that's where critical thinking comes in. Don't just memorize rhythms, blindly understand why they happen, what they mean for the patient, and how to respond appropriately.
Shift Fuel's last tip is all about practice, practice, practice.
Yeah.
They recommend using NCLEX prep materials like practice questions and simulations
Yes.
to really hone those skills.
That's where you'll really solidify your understanding and build that confidence you need to walk into the NCLEX feeling like you've got this.
I love that, feeling prepared and empowered. That's what we're all about.
Well, we've reached the end of our deep dive into ECG analysis, and I hope you're feeling a lot more comfortable with those squiggly lines and what they mean for patient care.
Remember, even though we have amazing technology to help us, nothing replaces a nurse's skilled eye and clinical judgment when it comes to ECG interpretation.
That's so true. We're the ones at the bedside observing the patient, connecting the dots, and making those critical decisions.
And with the knowledge you've gained today, you're well on your way to becoming an ECG superstar.
Awesome.
Keep practicing. Stay curious and trust your instincts.
Yes,
You've got this.
absolutely. We're your ECG cheerleaders rooting for you every step of the way. Good luck on the NCLEX.